Good afternoon, everyone. I'm thrilled to welcome you today to today's webinar, co-hosted by the USC Institute for Addiction Science and the USC Schaeffer Center for Health Policy and Economics. I'm Adam Leventhal, the director of the Institute for Addiction Science, and I'll be moderating today's webinar on the intersection of two pandemics, COVID-19 and addiction, featuring two of the nation's leading experts in understanding and fighting these pandemics. Rosalie Liccardo Pakula, a health economist and professor of the Price School of Public Policy of USC, and our very special guest, the 16th Assistant Secretary for Health, Admiral Brett Giroir, MD. Well, much like the Schaeffer Center achieves this in the area of health policy and economics, we here at the Institute for Addiction Science are breaking down the silos that have historically separated different addiction professionals. We're pioneering a new field called addiction science that promotes synergy across disciplines and an all-hands-on-deck approach to addressing the addiction crisis. With unprecedented breadth and depth, we are the nation's first comprehensive addiction institute with 63 faculty from 8 schools across the University of Southern California. We try to conduct novel, impact, cross-cutting research, educational, and community engagement programs such as today's webinar. So while COVID-19 needs no introduction, its intersection with addiction is what we will call to your attention in today's webinar. With national drug-related overdose figures spiking, the commercialization of high-potency cannabis products, and a new epidemic of youth vaping, and the long-standing epidemics with cigarettes and alcohol, we were already in a challenging public health position. And now with the COVID-19 coronavirus, people with addictions are experiencing unprecedented levels of stress, life changes, challenges accessing healthcare that could adversely impact their addiction and also render them more vulnerable to contracting and dying of COVID-19 coronavirus. So we will talk about these topics today and more in the webinar. While attendees are muted, you could submit your questions at any time using the Q&A feature at the bottom of your screen, which we'll address later in the hour. But now I would like to formally introduce Admiral Giroir. Brett is the 16th Assistant Secretary for Health at the U.S. Department of Health and Human Services. The Assistant Secretary for Health is one of the most important jobs in all of public health. In this role, Admiral Giroir leads the development of national public health policy for our country, including overseeing the Office of the Surgeon General, the Office of Minority Health, and Health Promotion and Disease Prevention. He promotes vaccination across the lifespan, is aiming to end the HIV epidemic and eliminate health disparities amongst the various goals of his office. He also serves as the senior advisor to the Secretary for Opioid Policy, which is responsible for coordinating HHS's efforts across the administration to fight the opioid crisis. And as a pediatric critical care specialist and physician scientist, Admiral Giroir has authored more than 100 scientific publications, editorials, and book chapters, held various leadership positions in federal government and academia, including being the former executive vice president and CEO of Texas A&M's Health Science Center. And also knowing Brett from our common interest in the youth vaping epidemic, I can assure you that he is also a champion for federal policies to improve youth health and well-being. Welcome, Admiral Giroir.
Thank you, Dr. Leventhal, Adam. First of all, I want to thank you, your team, for organizing this and everyone who's participating. My schedule is pretty busy right now, as you might understand, with COVID, working on the task force and testing, but I'm here for 2 reasons. Number one is because we absolutely need to pay more attention to the intersection of these two pandemics. While I spend my waking hours worrying about COVID and testing and what's going on, I probably spend my sleeping hours having nightmares about the coexisting pandemics and the impact on other public health. And I want to talk about that and certainly answer questions. The second reason I'm here is because of you, because your tremendous contribution and your institute's contribution across the board, but especially in our work trying to really attack youth vaping. Some of the work you did was instrumental in federal policies. you gave of yourself during holidays, late nights, and I just want you to know that we really appreciate everything you do, and I personally appreciate everything you do. I won't take much time, but I want to go through just a few level-setting pieces here. So if you can hit the next slide, please. This is a really concerning slide, and this predates the pandemic, but I wanted to get us all in the frame of mind. This represents the mortality, the overdose mortality, the estimated or predicted based on preliminary data from the CDC that looks at our overdose mortality over time. This was an incredibly sobering chart in the fact that we knew things were turning in the wrong direction, but our preliminary estimates of mortality in 2019 will show almost a 5% increase in deaths over 2018. Basically, all the progress that we made, if you follow that orange line, it has now been reversed, and this is even before the pandemic. So we will have over 71,000 deaths when this is finally confirmed. It's preliminary data, but the CDC is pretty compulsive. Their preliminary data is 99.8% complete. So unfortunately, this is the reality as we understand it. If you go to the next slide, please. Now, I have faces blocking the right side of that slide, but I just want to make it clear that we do have a lot of heterogeneity across the country. The darker orange is the worsening percentages of deaths. The blues are the improvements. And you see that there really is a diversity, that we have many states that are improving and continue to improve, although many of those states are improving less well than they did before. And we have many really concerning states. We've seen this a lot in the West, but now inching its way towards the East, and we'll talk about that. But you know, California up almost 16% is truly a disaster, not only because of the percentage, but because of the numbers of people that represents. So we have a very, very heterogeneous issues across the country with these last data. Next slide. What you can see here, and this looks at the overdose deaths by drugs, is that synthetic opioids like fentanyl still lead the pack. They account for the majority of deaths that we have. What you do see, however, though, is that prescription opioids, and we'll go into this a little bit more, have decreased. And I think we have done great work on that by all the work we've done about decreasing supply, getting rid of excess opioids in grandma's cabinets. I must admit, I went home to my mother who broke a pelvis a year ago, and after all I do, I found about 100 oxys in her closet because they had just given her all this and she never took it. And I was pretty shocked about that, and I did appropriate disposal with that. I think what we're all concerned about is the rising cocaine use and the rising methamphetamine use. And again, cocaine was actually decreasing for a period of time, and now it's increasing. And methamphetamine is really extraordinarily concerning, as I'm sure we'll talk about. The patterns are no longer single use, like maybe a person just, on their prescription opioids, but polysubstance use is pretty much the norm right now. And we've got to get out of this impression that if I take an upper and a downer, they cancel out. We know that methamphetamine and fentanyl are a particularly deadly combination, and it's really ravaging our country. Next slide. So we know that there are a lot of reasons to believe that overdoses will be going up during the pandemic. Hopefully my next slide is the OD map, but let me just talk about this. And we'll be publishing some findings about this pretty soon. Every indication we have in terms of stress, in terms of surveys about increasing use during the pandemic, basically everything is pointed in the wrong direction. And we know that there's so many reasons why this can be. All the factors we know that are associated: stress, isolation, loss of job, loss of employment, insurance, economic stress. It's just a nightmare for people who are suffering disorders or who have an issue of potentially doing that. Seeing people around them die, their family members die, or people in the hospital, incredibly stressful. And we also know, and we haven't put two and two together, and maybe Adam will, that we know that COVID also affects those who are highly vulnerable, minorities, Native Americans, Native Alaskans, people who we know because of the social determinants of health also bear a lot of the disproportionate burden of substance misuse and substance use disorders. We have been following some novel sources. Millennium Health is a national organization that does urine drug testing across the country. And we've been following that and are putting the data together. But it's one of our first, real-time signals, and it's really showing across the country that the patterns of polysubstance use and positivity have skyrocketed pre and post the public health emergency. We're working on quantifying that, but I think it just matches all the data that we have. And then finally, the next slide. This is, again, it's regional, but is our ODMAP submissions between January, April 2019 and the 2020 comparison. So ODMAP is another one of these real-time sources that we look at the real-time overdoses that are tracked by emergency departments, et cetera. And what you see is there's just a tremendous increase in overdoses in January, increasing in February, March, and April. That's all the data that we have from the May report. But we know that overdoses have gone up significantly. And I think on the right panel there, it's some percent increases there that you can see. So number one, we started at a bad baseline. And number two, everything about the pandemic is making it worse. So final slide. I think it's my final slide. We've been trying to do quite a few things anticipating that, and I won't bore everyone with that. But things like telemedicine and allow prescribers to prescribe buprenorphine to both new and existing patients through telemedicine. Expansion of Medicare coverage and telehealth services, very, very important to us. CMS issuing new rules to allow OTPs to do things through two-way interactive instead of just in person. Flexibility for methadone treatment to allow 28 days of take-home medications. So we've been trying to lean in as much as we can with regulatory authority, but we know it's not enough. And what I'm anxious to hear is what more can we do? What more should we do? What social programs do we need to have? What legislation do we need to have? And also, what things have we done that shouldn't stop with a public health emergency? A lot of these ideas seem pretty darn good to me that we have the authority to do only in a PHE, but we probably ought to be seeking them further. And I would say ongoing debates that are just there anyway. Has the waiver for buprenorphine, the X waiver, outlasted its time? Is it really time to just make this open to everyone? This is not 1990 anymore or 2000. So with that, I didn't mean to take up too much time, but I really appreciate being here and look forward to taking any of your questions.
Thank you, Brett. Wonderful opening remarks, sets the stage perfectly for all the topics we want to dive into. So now I'd like, joining our discussion, I'd like to introduce Professor Rosalie Liccardo Pakula. Dr. Pakula holds the Elizabeth Garrett Chair in Health Policy, Economics, and Law, and is a professor of health policy and management in the USC Schaeffer Center, the Saul Price School of Public Policy at USC, and is a member of the Institute for Addiction Science. She currently co-directs our institute's policy program, as well as the RAND USC Schaeffer Opioid Policy Tools and Information Center for Excellence. And prior to coming to USC, she served as co-director of RAND's Drug Policy Research Center for 15 years. Professor Pakula's research has focused on improving data and methods for better understanding which opioid policies are effective at tackling both the supply and demand for these drugs. And she's also worked a lot in the area of cannabis. So welcome, my dear colleague, Professor Pakula. tell us a little bit about the evolution of the overdose epidemic, Rosalie, and kind of what you've learned in your research are the types of policy strategies that potentially work and address this evolving beast.
Well, thank you, Adam. That's a very large question. I'm not sure I'm going to get to all of it right away, but I wanted to say it's really an honor and a pleasure to be part of this and to be here with Admiral Giroir. There are very consistent trends that Admiral Giroir's slides already showed to some extent. This has been a changing evolution in terms of the opioid epidemic, where first it was a problem with prescription opioid analgesics, which transitioned around 2010 into a problem with heroin, which then became a problem with fentanyl, now the illicit synthetic opioids. And while that part of the story is pretty well known, another piece of the story that perhaps is not as well known is the extent to which much of the drug overdoses that we're seeing today are polysubstance related. What I'm showing you now is a figure that was produced by my former colleagues at RAND, examining the problem of synthetic opioids, which have been driving the opioid crisis in the last couple of years. And while people are very familiar with the knowledge that fentanyl and some of these synthetic opioids have been mixed in with heroin and even with prescription opioids and have been a driving force behind opioid overdose mortality, as shown in the top 3 graphs of what I'm showing right now. What perhaps is not as well known is the extent to which these synthetic opioids are getting mixed with other drugs in the black market, particularly cocaine and psychostimulants. And as already noted by Admiral Giroir, there has been a rise in cocaine mortality and even psychostimulant mortality, largely driven by methamphetamine, in recent years. But that we're seeing an increased influence of rising overdoses in these drugs combined with other substances, and particularly fentanyl. And the importance of this can be seen hopefully in this graph. What I'm showing you on the left-hand side is that these are, the dark line is all cocaine mortality, cocaine-related deaths, which have taken off, as was already stated, since 2013, really. But on the left-hand side, we're showing you cocaine-involved deaths that involve synthetic opioids versus not involving any. And on the right, there's no other opioids involved. And what you can see is that it's really the cocaine-involved deaths that include synthetic opioids or other opioids that are driving the deaths in recent years. I wanted to raise this as a critical issue I'd like us to discuss in today's webinar, because I think it's really important to keep in mind that what gained attention is largely as an opioid epidemic has evolved into an addiction epidemic. And that treatment, well, we have identified some very effective and important treatments and improved our policies recently in addressing access to some of those treatments. They have largely been focused on the opioid problem. And particularly in light of the COVID situation, we need to not lose sight of our broader addiction problem and whether our policies can reach individuals who are struggling with addiction regardless of the substance. So I just throw that out there as a point that I hope we'll be able to come back to.
Thank you, Rosalie. So I want to also let Admiral Giroir comment a little bit about this. And you showed us some very concerning data, some late-breaking data about what we're seeing. And, you know, cocaine is not a new drug. Methamphetamine is not a new drug. What are some of the ideas and potential tools that you may be thinking about at the federal level that could potentially work and put us in a better position down the road so we're not cleaning up this, this very bad epidemic in the future?
So thank you. And again, I really appreciated all of those remarks as being, you know, really very, very important and spot on. So we started way back in March of 2019, a methamphetamine actually task force with Nora Volkoff and Ellie McCann's cats and all of us around the table as we saw psychostimulants really increasing And we've done a lot of things sort of in the long term, like opened up the FDA to new, showing the FDA is highly motivated for new treatments, having NORA and the FDA at the same table, bringing people in. So we've done a lot of sort of that sort of work, trying to build the future, provide new treatments, understanding new therapies. Some very practical things. I think, as you know, until last year, state opioid response grants were state opioid response grants. They couldn't be used for broad treatment. And I spent a lot of time on the Hill and in testimony, as everybody has, it said, look, we don't have an opioid problem. We have a substance use disorder problem. And we've just got to open that up so that people can access that money. You know, to me, you know, we don't make a value judgment that opioid disorder is worse than a methamphetamine use disorder or cocaine use disorder. So, and that happened very well. And I think that's very positive. We're also trying to build, you know, we don't want to play whack-a-mole, right? We have to get to the underlying issues and sustainability. And I'm really big on the sustainability questions because I don't have a magic bullet. And what we've really been investing in is like workforce and all across. You saw that HRSA just put $20 million for addiction medicine fellowships. That's really important. And we really want to focus that on primary care people who can help with substance use disorders, because it needs to be a primary care specialty, right? Not everybody can have an addiction psychiatrist. That really needs to be for people with a lot of comorbid conditions, but training social workers and peer counselors, all of that. Secondly, trying to get the reimbursement system right. Now that's really turning an aircraft carrier, but CMS has been very willing to do new models of sort of bundling care, because we've got to get the workforce right. And once you have a workforce, you have to pay them, and you have to have an appropriate system of care. So I think, you know, what I've been trying to do is sort of stamp out the whack-a-mole stuff, because you've got to do that. You've got to run to the fire, but really trying to make parity real for mental illness and physical illness, trying to create a workforce that is going to be equally good for smoking or vaping as it may be for opioids or alcohol or whatever the next drug is. And also spending a lot of time with the law enforcement community. And I'm going to tip my hat to Surgeon General as well, who's done this quite a bit. As you know, he's a Surgeon General. His brother's incarcerated for substance use related offenses. And I think we've made great strides, and I can't say down to every individual police officer, but at the national level, really making sure everyone understands that this is a public health emergency and you can't arrest your way out of it. And in fact, we want people outside of the criminal justice system into the public health system. So, I mean, that's a very general answer, but we are continually looking for new solutions, small scale, big scale, but long-term sustainability, because this is not going to be something we're going to complete in 2 years. I think this is going to be with us for tens of years until we ultimately get the underlying social determinants of health, resiliency in our communities, and that's not a quick fix.
Yeah, I would concur with all of that. I think that there's been a number of really important steps that have both federal and state policies that have been undertaken to improve addiction treatment broadly. And I think that these are really important, not the least of which is the most recent change in the 42 CFR Part 2 confidentiality for addiction treatment. By reducing the restrictions that previously had existed there, we've now improved the ability to coordinate care between addiction treatment and primary care, so that primary care can be informed about the needs, the additional needs of patients that they're seeing in the system. So I think more efforts and burial removals to coordinated care, I think, will be tremendously helpful for those who can and are able to afford treatment within the healthcare system.
And let me just say, Dr. McCann's Katz has been a real champion of 42 CFR to really get that reformed, and she really worked very hard on that. Couple of other things is we're really trying. I'm a big believer in FQHCs, community health centers, and because it really is a holistic care. You get physical needs, but you can also get behavioral disorders, as well as now increasing substance use disorders. And again, They take care of 30 million people, 1 in 3 of those in poverty, 1.3 million homeless, 1 million migrant workers. So anything we can do to support them. And let me tell you, Adam, we talk about the big picture, but what I'm writing guidance on now, and we're just about to put this out, is police officers and emergency responders are afraid to give naloxone now because of COVID. So you want to talk about an intersection because they're afraid to, nasal administration. They're not public health people. So even when it comes down to simple things like that, making sure people know that it's safe to administer naloxone. Because if I've got a gown, glove, put on an N95, put on a garment before I give naloxone, you lose the benefit for that. So, even simple things like that, we've got to be constantly on top of.
Yeah, and you are absolutely right. And, the idea of an all hands on deck approach, multiple levels, it's not just the discovery of new medications, it's how do we get these to people? Not just involving the healthcare system, but also involving criminal justice system, the police force. So that's how big the set of interrelated epidemics are. And not to be all doom and gloom, but you also mentioned that all these things that we put in place, like life-saving naloxone, they're complicated by the pandemic. So I want to shift gears a little bit, and we touched on this. Let's talk a little bit about health equity. This has been a big issue overlaid with the pandemic. We know that people with substance use disorders across the board are more likely to be members of a disadvantaged population, certain ethnic and racial minority groups. And Admiral Giroir, as one of the many things that your office oversees, is the Office of Minority Health. So could you talk a little bit about the potential intersection there? And you also mentioned that we are seeing some disparities emerging already with COVID-related deaths. And so, how do we keep these things from synergizing and blowing up?
Well, they are synergizing, and that's Native American, Alaskan Natives, and African Americans have hospitalization rates for COVID 5 times whites. Hispanics have hospitalization rates 4 times whites. And I've said it, and I don't want to be misinterpreted because this is a tragedy that we're all in, but if there is a sliver of a silver lining, it has hit America across the face with the underlying disparities that have plagued our system for the last decades, if not century. And I think people are understanding because it's so, it's so blatant there with COVID that we've really got to get to the underlying disparities to solve this. And, while I'm all happy about remdesivir, which is great, having an African American in an underserved area get their blood pressure medicine is probably a whole lot better than remdesivir. So you're seeing, and we've been able to catalyze a lot of efforts. You'll see some more. We started a new national infrastructure based on Morehouse School of Medicine. We awarded $40 million, which is a lot of money for my little office, to create a really national infrastructure that's focusing on COVID now, but also getting people ready for vaccines. Because how awful would it be because of historic mistrust in the system or lack of access or, bad things on all of us for experimentation on underserved minorities way in the past, if we had a vaccine, but the most needed in our communities don't get it. So we're trying to work on all of that now. It's a long-term thing, but again, everybody understands now what we've been preaching for a long time about health disparities, and you've got to move the curve to the left. Saving $1 off an amputation in a hospital by getting them out early is not where we need to be. We need to be way upstream at diabetes control, at providing appropriate nutrition, elimination of food deserts, et cetera. Don't get me started because this is my day job. What I really came here to work on. But we're seeing this really, the manifestations of our historic disparities are really just in everyone's face right now.
One of the things that I don't know is well understood, while prevalence rates of many of the substances are lower or just on par. When I talk about prevalence rate, I mean use in the past 30 days or use in the past 12 months, and annual prevalence rate. Use by minorities are generally, for most substances, below that of whites in general. But when you look at the rate at which people escalate from any use to more heavy and ingrained use, it is much higher risk among minorities, which is telling us that we are missing, perhaps through the healthcare system, perhaps through our other systems, an opportunity to really attach and communicate effectively about the risks of excessive use of all substances, whether you're talking about alcohol or you're talking about prescription opioids or an illicit substance.
Brett, if you're trying to talk, you're muted right now.
No, I'm just telling my aide here that I got to get that data from Dr. Pakula because I really want to see that. That's important. I want to repeat it and proselytize it. Yeah. That's what I was saying.
We'll get over to you. She's probably talking about the NSDUH data. Was that?
It's one of several sources.
Yeah, one of several sources, and it's complex. And Admiral Giroir, you talked about American Indian, Alaskan Native. They still are sky high on almost everything, unfortunately, and we're seeing this with Pacific Islanders, and we're seeing this also in terms of trends over time. Our policies are working, and we've made lots of strides in a number of different areas and addressing addiction, especially in combustible tobacco use, right? But it's just they're disproportionately benefiting certain majority groups and more advantaged groups. So we do have a little bit of a ways to go there.
I think you hit the nail on the head right there in terms of, I often get in discussions about the fact that we've had this war on drugs for quite some time. And I try to provide information that suggests, no, actually we have moved pretty substantially toward recognition of this as an illness. I'm not saying we're there, but I am saying if you look at the amount of resources in providing access to treatment as well as coverage, insurance coverage for treatment, the problem is that many minorities are not getting access to that health care in the first place, a point again made by Admiral Giroir. Federally qualified health centers are one of the avenues where they can. I think the other promising avenue today, because of the COVID, is through telemedicine. And the ability to use telemedicine to access not just other types of, general health care, but psychotherapy and specifically. Rules and restrictions that you must have a video teleconference in order to engage in that, that's limiting to people who are living in areas with weak internets or poor electronics. Being able to do this over the telephone could be substantially more effective in targeting our research group, our services to those who are in high need right now, particularly given people are experiencing such isolation.
Absolutely. Well, I want to switch gear to some Q&A from the audience and just also give a shout out to the American Society of Addiction Medicine, their website. They have some good resources on how to get remote and telehealth, including 12-step programs too. So let me just start with the first question. It's from Leanna Treitler, who is a rising junior here at USC, who I know actually she's already written a book on addiction already, so she might be gunning for both y'all's jobs. But she's interested in the impact of the pandemic on youth, right? And so this is having a large impact on college students, high school students. There's in so many ways, their lives are just shaken up. And we know that if that's likely to affect everybody's well-being, and to the extent to which people are doing well mentally is very closely correlated with their willingness to experiment and use substances. So let me start with Admiral Giroir. You are a pediatric healthcare practitioner. What are some of your thoughts about the impact on youth, concerns and potential opportunities to help this population?
I'm of course, like all of you, very concerned, and I do think the academic community really needs to dive into this because the data all look not good, but we know children are resilient. Just explaining what's going on. My 3-year-old granddaughter doesn't understand why grandma can't, great grandma can't go over and why can't she have a party and where's school? I don't know what that's going to do over a period of time. We know that adolescents, at least the data that we have, drug use, suicide attempts, all of that are going in the wrong direction. You guys are the practitioners. I try to never use social distancing as a term, and whenever I do, I hope people correct me. I think there's a big difference between physical distancing and social distancing, and I want people to be socially closer but physically distant, because I think that's really, really very important. I think we need to try to, as you've heard, I'm not proselytizing about this, but to the degree that we can get children back in physical classrooms with each other, that in some places it's going to be easier than others because we have major outbreaks across the Sun Belt. It's going to be very hard to do that. And I have to think even 2 days a week in a cohorted class is better than no days a week not being exposed to your teacher. So I don't have the answer to that, but we do welcome. And by the way, that rising junior or senior, we'd love to have you as an intern in my office anytime you want to come, or as a fellow. So we need bright young people to come here.
I'll pass along your cell phone number to Leanna.
She's probably the only person who doesn't have it in the country right now, so that's fine.
Right. Absolutely. So another question from the audience, and this one is about the commercialized drugs. So this is Jian Shiomitsu. I'm sorry if I'm not pronouncing it correctly. Prevention Unit Coordinator at the Asian American Drug Use Program in Los Angeles. But she is concerned about if there's data on levels of alcohol, marijuana, and illicit substance use amongst households since we had the stay-at-home order here in California and, of course, many other states. And then to what extent might delivery of alcohol or cannabis or other substance be impacting that? And then, of course, here in California, there are some interesting policies about what is an essential business, including cannabis dispensaries was included here. So first, let me throw that over to Professor Pakula. Go ahead and give us your thought about the illicit and commercialized substances.
So sales data is our primary indicator for use right now because it takes a while for the survey, many of the survey data, although there are several online surveys that are suggesting that use is rising and that sales data is indeed following and reinforcing that conclusion. There was a study done by USC Marshall School that showed that rise in alcohol sales, which is even interesting in light of the fact that there's also a shift in where people are getting their products because of restaurants for a while closing, and initially they couldn't deliver with alcohol. Then California, as one state, for example, changed so you could deliver alcohol with your meal if ordering from a restaurant. So some of the delivery services have certainly enabled the opportunity to retain access, I say, because it's really the question, the excessive use is on the part of the consumer who's making a choice largely because of the increased stressors. We know between the stress of having to stay at home, care and teach your children at home while doing your job so you don't lose your health care or so that you have income. These are difficult things for families to do. It's a difficult ask. These are unusual circumstances and that does generate stress. The one thing, and the other note that I made to you, Adam, beforehand, is that many people who have legitimate needs for prescription opioids are being given large doses because they're having to shelter in place and need access to their medication. So what that means is that there's at-home access to many of these substances. There was a general theory among drug policy researchers that the COVID-19 would shut down borders and actually reduce supply. We haven't seen that, not just in the US, but abroad. And so these concerns about addiction and the preliminary data that Admiral Giroir showed are all telltale signs that we need to be prepared. Our healthcare system needs to be prepared and our social systems need to be prepared for increases use. And we need to think of ways of reaching into people's home to help them manage this, either through telemedicine, or there's actually a lot of really good therapeutic apps that you can use on your phone or on your computer to help deal with stress.
Admiral
So
Giroir?
just to say, I think those comments are perfect. It hasn't shut down the drug flow, but without getting into all the intelligence sources, we know there is a huge buildup of drugs ready to pour into the country from the relatively lessened flow that there's been. So I think it's important for everyone to understand that, and to some degree, as you know, the illegal distributors are driving some of this demand by enticing packages or mixing substances, so there's mixed addiction. So I don't want to rain on that parade, but there is a large surplus that particularly the cartels are going to push as soon as things open up more.
Which means prices will be falling.
Absolutely. Yeah, the supply and demand. Of course, we're seeing it, and whether we're talking about legal drugs, illegal drugs, the black market, the illicit market, everything all ties together. So, we're almost out of time. So I think what I'll do is, because I know Admiral Giroir needs to save our country right now from a terrible pandemic, and Rosalie needs to study it and help us figure out the policies that will save us. I wanted just to take a moment to thank our audience. We had a massive audience today, so thank you for sticking with it. We hope that you found it informative. The video will be posted online, and you can view it on our Institute for Addiction Science webpage, and also on our YouTube page. And we invite you to follow us on Twitter and Instagram. Our handle is at IASATUSC, at IAS@USC. So thank you so much to the Schaeffer team, Monica, Kim, Kuklavera, the IAS team, Lauren Whitted, Reed Whaley, and NASA. Thank you to your office, Admiral Giroir and Lieutenant Commander Banty. And a big thanks to both of you so much for spending your time addressing this very important issue, Admiral Giroir, Professor Pakula, and your very cogent discussion. So with that, I will say adieu to everybody and wish you well. Thank you.
Thank you, Adam. Thank you.